Good morning, everyone, and welcome to this session on trauma-informed practice and suicide prevention. It's really great to have everybody here. We know there's been a huge amount of interest in this session today. I am Haylis Smith. For those of you on the call that haven't met me before, I'm the National Delivery Lead for the Suicide Prevention Strategy and Action Plan in Scotland, and I'm really delighted to be chairing this session this morning. We will obviously be talking about suicide and about trauma over the course of this morning. So I just want everybody to be looking after yourselves, be aware of your own little internal monitoring system, and if you start to feel that I'm not sure if I still want to stay on this call, then please take some time away from the screen. There'll be some links in the chat to sources of support, and I would really encourage you to seek some support if you feel that would be helpful. As I said, we've had lots of interest in today's event, so I think we had over 600 people registered, so it's really great that there's that amount of interest. We'll be hearing briefly about the work of the Suicide Prevention Scotland and what we are doing to deliver the strategy and action plan. We'll also be hearing from Laura about the National Trauma Transformation Programme, and we've got inputs from a range of colleagues who will be sharing their learning and approaches to joined up working across these two agendas. We'll also allow time to hear from you about all your work, and questions and discussions will happen later in the session right at the end. I guess both our suicide prevention strategy, our self-harm strategy, have the importance of trauma-informed and responsive services and systems and workforces throughout them in helping us to prevent suicide and support people who self-harm. And through the National Trauma Transformation Programme, Scotland's really paved the way for creating a vision of a trauma-informed and responsive workforce and services that can recognise where people are affected by trauma and adversity, and be able to respond in ways that prevent further harm, support recovery, address inequalities and improve people's life's chances. So this session's been organised by Scottish Government, by COSLA, Suicide Prevention Scotland and the Improvement Service. We've really come together to make sure that we are delivering a session that will be of interest across these topic areas. It's been in response to what we've heard from our networks, including our local suicide prevention leads and local trauma leads, about wanting to have some time and space to join the dots across those agendas and make some connections. So we wanted to bring colleagues together who are working on one or more of these policy areas to make those connections, join the dots, share the learning, inspire each other and identify where we might support each other to strengthen those links across the two agendas. We hope today is the start of conversations about how we can collaborate together across this work and how we can effectively and sustainably pool our capacity and resources and expertise to support people and communities affected by trauma and suicide. We recognise that many people on this call today will be affected by suicide or trauma, whether that's in our personal lives or through our work or both. And we know that this work requires a range of expertise, including expertise by profession, expertise by experience, and expertise by leadership. And we've got an incredible mix of colleagues from across Scotland joining us today. So we're going to kick off this morning by hearing from Myra Ross, who works in public health improvement in NHS Highland, who is going to share a poem that she has written that's really relevant to this topic. So Myra, I'm going to hand over to you. Thank you.
I wish someone would ask me, "How are you today?" and gift me enough silence to find the word to say. I'm frightened, I'm exhausted, and I don't think I want to stay. But he says he'll tell the social, and they'll take my kids away. And he tells me that he loves me, and it won't happen anymore. And I tell my neighbours how I've walked into the door, and he tells me I enrage him, and these things I make him do, and I wish somebody could ask me, but really, how are you? I wish they wouldn't judge me, that they wouldn't tell a soul, that they'd take the time it takes for my story to unfold. I wish someone could come save me, crack the glass and break right in, set his silly little spider free and safe again.
Thank you, Myra. I've heard that poem a few times now, and it always gets to me. So it's a really great way of starting off the day and helping us understand the impact that trauma can have on people. I'm really delighted this morning we've been joined by Councillor Paul Kelly, who's the Health and Social Care Spokesperson at COSLA, and also Stephen Gallagher, the Director for Mental Health at Scottish Government. So Paul's going to say a few words to start us off, and then we'll hear from Stephen.
Thank you, Haylis. Just checking, colleagues can hear me okay?
We can, Paul, yeah.
Yeah, great. Before I start, managed to remember to take the microphone off mute. Good morning, everybody. I'm Councillor Paul Kelly. I'm COSLA's Health and Social Care Spokesperson. And for those of you who are maybe not aware of the role of COSLA, COSLA represents Scotland's 32 local councils in issues directly dealing with the Scottish Government, stakeholders and other partners. And it can be around national policy or local issues and local policy. So as I say, I'm delighted to join you today for what I'm sure will be a really useful and meaningful discussion on suicide prevention, self-harm and embedding a trauma-informed and responsive approach. I just want to echo what Haylis has said. It was very moving to hear Myra's poem to start the day, and I think puts into perspective how important the work is that we're all doing collectively across the country, and highlighting again how important this work is. So thank you, Myra, for that. The well-being of individuals, families and communities, alongside supporting the most vulnerable, is currently a top priority for COSLA. Within local government, we provide a range of services that support mental health needs, from digital support and community and school-based counselling, through to support provided by mental health officers when individuals become seriously unwell. The wider services we provide, such as education, social work, housing, and employability, are also often critical for those with mental health or wellbeing concerns. We, alongside many of our partners, recognise the importance of support and services being trauma-informed, making support more accessible and feel safer for those who need it, and the role this may have in reducing the prevalence and impact of suicide and self-harm. This sits alongside our understanding of the critical nature of early intervention, providing the right support at the right time as early as possible. And we continue to work together alongside the Scottish Government to progress both of these agendas. In recent years, a strong collaborative approach has been taken between COSLA and the Scottish Government to progress shared ambitions around mental health. Working across spheres of government allows us to provide local and national leadership around mental health, raising awareness and seeking to bring change across and beyond our respective organisations and spheres of influence. Our joint commitments have included the National Mental Health and Wellbeing Strategy, which was published in 2023. This sets out a vision of a Scotland that is free from stigma and inequality, where everyone fulfills their right to achieve the best mental health and wellbeing possible. The strategy and its associated action and delivery plans outline how we must promote positive mental health and wellbeing for the whole population, prevent mental health issues from occurring or escalating, and provide mental health and wellbeing support and care, ensuring people and communities can access the right information, the skills, the services and the opportunities in the right place at the right time, using a person-centred approach. This strategy provides an overarching framework through which to bring together our wider joint work. Creating Hope Together, our suicide prevention strategy, where we seek to reduce the number of suicide deaths and tackle the inequalities which contribute to them, as well as ensuring those affected by suicide can get the help they need and feel a sense of hope. The world-leading self-harm strategy and action plan, where new supports and services are actively providing peer support and professional training. Community supports and services which are funded by the Scottish Government and provided by local authorities to provide support to children, young people and families around well-being and emotional distress. Nearly 83,000 people have accessed these services between July 23 and March 24. And crucially, the development of a trauma-informed and responsive workforce and services that can recognise where people are affected by trauma and adversity and respond in ways that prevent further harm, support recovery, address those inequalities and improve life chances. I would emphasise COSLA's absolute support for these areas of work. Being able to consider this work collectively provides the opportunity to embed key activities across different policies supporting greater alignment across our work, greater impact, and streamlining the asks made of the workforce who are already under significant pressure. This applies, for instance, to how we seek to tackle the inequalities that determine the likelihood of experiencing poor mental health and self-harm, and how we ensure everyone impacted by self-harm or suicidality receives compassionate support without the fear of stigma or discrimination. We want to embed these approaches appropriately across the breadth of work we undertake. Work to progress this can be taken forward through our continued commitment to embed a trauma-informed and responsive approach to supporting people and meeting their needs across our workforce, systems and services. The work of Suicide Prevention Scotland, our National Suicide Prevention Delivery Collaborative, the Creating Hope Together Strategy Delivery Plan, and our approach to time, space and compassion. I'm looking forward to the rest of this morning. I can only stay till 11 o'clock, but I hope for everyone that it's a very productive morning and that we can share our ideas and work together on the areas I've outlined. So thank you. And I think I'm handing back to Haylis.
Yeah, thank you, Paul. Great to hear from you. Stephen, do you want to take over from there?
Thank you, Haylis, and good morning, everyone. And thank you, Councillor Kelly, for those introductory remarks. The Minister, Marie Todd, is unable to be here today because she's in Parliament for Stage 2 of the National Care Service legislation. So you're stuck with me as Director for Mental Health, but I'm very happy to be here in her stead. Look, the first thing I probably want to say is that the poem that we reflected on a few moments ago from Myra Ross never fails to have impact, I think. And probably the first 5, 6, 7 lines of that embody that call for an approach which is based on time, space and compassion. So time, space, compassion is a set of principles which Haylis will refer to later in her input this morning, that can be embedded across a wide range of services and settings in which we believe can make a real difference and ultimately save lives. Back in 2023, the Government and COSLA published the Time, Space, Compassion Introductory Guide. I'm not sure whether you will all have seen that on the call. And the product of 3 years research and the work with people who are expert by experience, practice and research. And those time-space principles, time-space compassion principles, reinforce the importance of listening, of trust and of relationships, and how these simple actions can reduce the impacts of suicide and of self-harm. The principles describe what compassionate support means in practice, using the language, experience and perspectives of people with lived and living experience, and the principles provide a reflective framework that can be used to support a culture where time, space and a compassionate response are the norm. We live in a world, don't we, where many services feel transactional. At its core, time, space and compassion is relational. And we need to know the difference between when relational versus transactional approaches are the best. We need to learn from and take action. So we acknowledge that we're on a journey, but we're definitely not at the start of that journey. And over the past 2 years, the Scottish Government and COSLA have worked closely together to promote and build opportunities for services and communities to share their learning and work on time-space compassion, embed time-space compassion in policy and mental health policy and in guidance and frameworks, and put time-space compassion at the heart of the work and the purpose of Suicide Prevention Scotland. And we've also worked together to take a whole of government approach. And that means working in partnership with Samaritan Scotland. We are working directly with a range of policy teams who have made a commitment to either integrate or mainstream suicide prevention into their work. We very much value the opportunity to come together today to create this important space for us all, to learn from others working towards the same aims, listen carefully to the experience, learning, and importantly, the barriers that sometimes you face in embedding trauma-informed practice and time-space compassion in practice, and to thank you for the fantastic work, often unspoken and unrecognised work that you do every day and that you already do every day. I think to conclude, it's really important that national and local government listen to and understand more about what's happening across the country. It's always a surprise when we stop and really listen to what's going on, what is under the radar, what we've not been aware of in terms of practice and issues, what works, how we can build on that, and how we can make this easier for this great work to flourish and to grow in the months and years ahead. Haylis, thank you very much, and I'll hand back to you now.
Thank you, Stephen, and thank you, Councillor Kelly, for joining us this morning. I know that you're both busy people, and I know that, Paul, you're having to drop off about 11, but it's great to have you here to be part of this session. And thanks for your words this morning. I think it's really important for us to hear those from both COSLA and Scottish Government. We're going to now hear a brief national overview of the work, firstly around the National Trauma Transformation Programme from Laura, and then you'll be sick of the sound of my voice by the end of this morning, so I'm going to do a bit of a roundup of the work around suicide prevention. They're definitely not exhaustive presentations. Laura and I have split the 15 minutes between us, so it's a quick quiz through both our respective areas of work. So we'd encourage you to have a look at the links that are in the chat for more information on both the suicide prevention work and the trauma transformation programme. So Laura, I'm going to hand over to you first and then I'll come in.
Fab, thanks, Haylis. And just to say, yeah, these are definitely kind of starter for 10 inputs on both of these policy agendas. So please do take a look at all the resources that are available online around them. So yeah, delighted to see so many of you here today. I'm Laura James. I'm the National Improvement Lead for the our trauma work at the Improvement Service, and the IS is the National Improvement Organisation for local authorities in Scotland. And since 2020, we've been supporting local authorities and community planning partners with strengthening capacity and capability around embedding a trauma-informed approach across services, systems and workforces. So as I said, I'm here today to give you a super brief introduction to the National Trauma Transformation Programme. I won't be talking in any detail about what trauma is or really what trauma-informed practice is, but you can find out much more about those on the NTTP website, and a link is in the chat. Can I get my next slide, please, Jenny? So the Scottish Government and COSLA have a co-owned ambition for a trauma-informed workforce and services across Scotland, capable of recognising where people are affected by trauma and adversity, that's able to respond in ways that prevent further harm and support recovery, and can address inequalities and improve life chances. Can I get my next slide, please? So the National Trauma Transformation Programme is a major and long-term change programme which aims to support Scottish Government and COSLA's joint ambition. It provides a wide range of learning resources, guidance and implementation support for all sectors of the workforce, and crucially including leaders, to upskill staff to the appropriate level of trauma-informed and responsive practice, and really critically to embed and sustain this model of working across our systems and services and organisations. Can I get my next slide, please? I just wanted to flag there's a number of national partners supporting this work, including ourselves at the IS, NHS Education for Scotland, Resilience Learning Partnership, COSLA and Scottish Government, and that brings together expertise by profession, leadership and experience to support the work of the NTTP. Next slide, please. Now, I know you won't be able to read much of this slide, but it is available on the NTTP website. But I really wanted to start early on with this logic model that we've developed as part of the national NTTP programme, because it really helps us to start to coalesce around outcomes. I think often we get very focused on activities and the things that we're doing, and maybe not so much on outcomes. So this logic model really starts to try to give us some consistency across Scotland around what we're all trying to achieve when we're talking about embedding a trauma-informed approach. And it's really designed so that we can see there are multiple benefits to embedding a trauma-informed approach in our services and systems and across our workforces. And that's for staff, for helping them to feel safe and well and supported at work and better able to do their jobs and support people. For those of us with lived experience of trauma, it's about how can we reduce barriers to accessing universal and specialist services whenever we might need them, making so that systems are easier to navigate, and so that services and systems are co-designed by expertise, by profession, expertise, by experience, and that leadership as well. And really thinking about, well, the benefits of embedding a trauma-informed approach. Actually, this work is supporting the outcomes and priorities we're already working towards in our services, our organisations, our systems and our local areas, really ultimately aiming to improve outcomes and life chances and reduce inequalities for people and communities across Scotland. Can I get my next slide, please? I won't go into these in any detail, but the NTTP has developed a number of freely accessible resources, and I really encourage you to look at the website and make use of them. I just wanted to highlight a few key ones. NHS Education for Scotland developed the Knowledge and Skills Framework, which outlines what any person in any job in any organisation needs to know and be able to do to respond appropriately to anyone who's experienced trauma. And there's different levels of knowledge and skills required depending on someone's job. The Scottish Psychological Trauma Training Plan lays out the how-to, so it's intended to support managers and organisations to work out how to turn the knowledge and skills framework into a reality. And then there's a number of freely accessible online training resources that anyone can access and use. And then we also have the roadmap for creating trauma-informed and responsive change, which is that evidence-based self-assessment tool that is designed to support implementation within organisations and systems, and really think about how you take a whole organisation approach. And then there's lots of other resources on the website, including case studies, briefings, videos, reports, etc. And also just to flag that Scottish Government have also funded a number of different tests of change or routes to implementation in different policy priority areas. This includes maternity, social work, and victims and witnesses and justice. And this is to really provide learning around what works in terms of implementation and develop that evidence base in the Scottish context. Can I get my next slide, please? There's lots of work happening across Scotland. Far too much for me to cover here, but that's within organisations with a national remit and across local areas. And increasingly, we're seeing a huge variety of services working to embed a trauma-informed approach. So that's anyone from road services, HR, customer services, libraries, social work, housing, dentists, substance use services, maternity services. And I think this really helps us to see how trauma is everybody's business, and how colleagues and organisations are increasingly recognising how a trauma-informed approach can support them in their work. But for today's purposes, I want to really highlight in particular the local infrastructure that's supporting this work, and we're really happy that many of these colleagues will be here today on this session. We have local trauma leads who are working across local authorities and health and social care partnerships who support the coordination of this work, trauma champions who are senior leaders who've been nominated to drive this work forward at a strategic level, and transforming psychological trauma implementation coordinators who are clinical specialists supporting this work as well. Next slide, please. And I just want to highlight the approach that the NTTP is taking with this work, and really making that shift from thinking about individual workers' practice to that wider organisational transformation and systemic implementation. We know that workforce training is a key component of any organisation's journey to becoming trauma-informed and responsive. Equally important are the culture and environments and supportive ways of working in an organisation that can enable sustainable change, which we know will ultimately make a difference to all of us who are affected by trauma. So the approach from the NTTP is really to think about how can we all work to embed a trauma-informed approach holistically across all parts of how our universal and specialist services and systems operate, so that training and individual workers' practice is not the start and end point of this, but it's about culture change. And this slide really highlights some of the key areas that we focus on in the roadmap, but I'll let you look at those in your own time. Next slide, please, Jenny. This work takes time and it can't be all done at once. And I think an absolute key part of this journey is about collaboration and joined up working, and thinking about how we can creatively pool capacity and resources across different services and policy areas, and really thinking together about how we can do things differently, reduce barriers to accessing support, and ensure that those of us who need it can access the support we need as early as possible. Those messages that Councillor Kelly and Stephen were talking about earlier. So that's why it's so great that so many colleagues from across the trauma work, from across suicide prevention and self-harm are together today for the start of that conversation and creating and making those relationships. Can I just get my last slide, please, Jenny? I just wanted to finish by highlighting that we're seeing a commitment to embedding a trauma-informed approach increasingly included or embedded across national strategies, action plans, practice guidance, and some legislation across a huge range of policy areas, obviously including suicide prevention and self-harm strategies and action plans. And I guess this is really important to emphasise for a few reasons. A trauma-informed approach isn't going anywhere, and it's increasingly being recognised as important to delivering many of our existing local and national priorities. So I think it's really helpful if we can see this not as an additional demand, but a supportive demand, and that embedding a trauma-informed approach is one of the many tools and opportunities we have in our work to improve outcomes for people and communities. So thank you all for listening. I want to encourage you to take a look at the NTTP website and make use of the resources and link in with local and national support. I'm really excited to hear the discussions today. So I will pass back to Haylis. Thank you, Haylis.
Thanks, Laura. Well done for sticking to time. Here's hoping that I can do the same now. I've got to chair myself. So I've already introduced myself. I'm the National Delivery Lead for Suicide Prevention Scotland, and that's the overarching delivery collective for our work on suicide prevention and to deliver the Creating Hope Together strategy and action plan. Jenny, could I have my next slide, please? So Creating Hope Together is our 10-year suicide prevention strategy, and our first 3-year action plan. These were published in 2022 following an extensive engagement, public engagement, where we held lots of sessions where people came to tell us about what was working well and what wasn't working so well, and where we needed to go next with our strategy and action plan. And with advice from our previous suicide prevention leadership group, we took an outcomes-focused approach to developing this strategy and created these 2 documents, which I would encourage you to go and read. But I'll give you a quick whiz through. So Jenny, could I have the next slide, please? So the vision for Creating Hope Together is that we reduce the number of suicide deaths in Scotland whilst tackling inequalities which contribute to suicide. So we know that suicide doesn't happen equally across our community, and that communities of place and communities of interest can have a higher risk of suicide, and we want to really begin to address those inequalities which contribute to that increased risk. We know that in order to be able to do that, we need to encourage all sectors to come together in partnership and to support our communities to become safe, compassionate, inclusive and free of stigma. And our aim really is that anybody who has thoughts of taking their own life or who are affected by suicide get the help they need and feel a sense of hope. And hope was the key thing that we heard when we were engaging with people around what needed to be in the strategy. People really felt that hope needed to be central to that. Next slide, please, Jenny. So our strategy has 4 long-term outcomes, and remember this is a 10-year strategy. So we, I haven't got a driver diagram like Laura has, but we do have an outcomes framework that we've put together. That the link is on the slides. I'm sure the slides will be shared after this event. Our first outcome is around ensuring that the environment we live in promotes the conditions that protect against suicide. And so that's really taken a sort of whole of government and whole of society approach to suicide prevention. Our second outcome is ensuring that our communities have a clear understanding of suicide, the risk factors and how to prevent it, so that we're able to respond in a helpful and informed way when people need support. Our third outcome is to ensure that everybody who's affected by suicide is able to access high quality, compassionate, appropriate and timely support, so that we know that people can get the right help at the right time in our communities. And our fourth outcome, for people who are outcomes purists, will realise this is a bit more of a processy outcome than a sort of standard outcome you might expect. But we felt it was really important that we were delivering this work effectively in collaboration, that it was being driven by the lived experience insights, by practice, by data and by research, so that we were confident in what we were doing and taking forward. Next slide, please, Jenny. Thank you. So we also have 7 guiding principles, which are really the things that talk about how we will do this work, not just what we're going to do, but how we're going to do it. And so number 1 is around ensuring that we are addressing inequalities and issues around diversity. We want to make sure that we are co-designing, co-developing, co-delivering our work alongside people with lived and living experience. And we're very fortunate to have a lived and living experience panel, a youth advisory group and a participation network who help to support that work, as well as many other organisations now who are bringing that sense of diversity and inequalities into our work and really helping us to shape how we do things differently and move away from just a population approach to suicide prevention. We also want to make sure that the voices of children and young people are really central to the work that addresses their needs. And as I talked about there, we have our youth advisory group who help with that, but we also have a participation network which is made up of over 50 organisations now who work with children and young people, who come together regularly to help shape the work that we're doing, and that's open to any organisation. So if you're on this call and you're an organisation working with children and young people, please get in touch and we can link you into that as well. We want to provide opportunities for people across sectors to come together to learn and connect, and we've run a series of webinars and events to enable that to happen, and we'll have our next big conference in May this year, so we hope to get information out about that over the next week or so, so please look out for that and come and join us for that. We've talked about time-space compassion already a few times, and that really is our core to how we want people to experience our support and our way of working to be sure that we are creating the time and the space and the compassion to enable people to connect. So it's really central to all our work around supporting people's wellbeing and recovery. We're also continuing the work around addressing the stigma related to suicide through all of our work, and we've been working really closely with our partners in CME to help to drive that forward. We know that there's been some progress made over the last 20 or so years, but we know that there's still an awful lot of stigma around suicide, and we want to make sure we're addressing that in whatever way possible. And as I've already described, we want to make sure our work is evidence informed and that we will continue to build that evidence base. So we're very fortunate we have an academic advisory group who support us with research and academic advice, our lived experience groups, but we also have connection to a wide range of practitioners now who are working on the ground and who help us shape our work through their knowledge and their understanding of what's happening at a local level. Next slide, please. So we've talked about Suicide Prevention Scotland, and this slide, I know it's not always easy to see, but this really kind of captures what Suicide Prevention Scotland is. And it's not just me and a few people sitting in a room. We really hope that Suicide Prevention Scotland helps to create that network and community of people and organisations who have an interest in or who are working in suicide prevention across Scotland. So there's myself as the National Delivery Lead. We also have our strategic outcome leads. So each of the 4 outcomes that I've already described are being led by one of our partner organisations. So outcome 1 is being led by Samaritans. Scottish Action for Mental Health, or SAMH as many people know them, are leading the work on outcome 2. Penumbra and Change Mental Health are working together to lead the work on outcome 3, and outcome 4 work is being led by Public Health Scotland. Alongside that, we have a huge number of organisations who come together to deliver specific actions in our action plan. So we have work through NES, through CRUISE, through Scottish Recovery Network, and many others who I can't actually name off the top of my head, but we probably could fill another slide with the number of people who are involved with the work that we're delivering through the action plan. It's also really key to understand that this work doesn't just happen at a national level, and we are, really fortunate to have local suicide prevention leads across the country who, are tirelessly working to deliver suicide prevention activity in their local communities. And, we feel it's really important that we create the space and the opportunity for those local leads to come together with people working at a national level, so that we are able to learn from each other and share practice, and also to help to develop and design the work that we are doing at a national level as well. And then we have our wider suicide prevention community, which, as I've said, we want to make sure that we're creating spaces for anybody who lives and work, or who is interested in or works in suicide prevention or any related field, really, to come together. And our conferences and events help to do that. We've talked already about our lived and living experience groups and our academic and practice evidence, and the whole strategy and action plan is led jointly by Scottish Government and COSLA, and I report jointly to both organisations. We're also very fortunate that we have a National Suicide Prevention Advisory Group, and I know that there are some members of that group on this call today who are coming from different perspectives, representing groups who face stigma, discrimination, or the inequalities associated with suicide, increased suicide risk, and they help guide and advise us as a delivery collective, but also Scottish Government and COSLA on where our work should go next. And final slide, please, Jenny. So in total, we have 31 actions and 70 policy commitments in our Create and Hope Together action plan, which runs until next year, the beginning of next year. We are working across sectors and with, as I've said, many organisations to deliver on these actions. What's on your screen at the moment is a summary of these actions, so I would encourage you to go and have a look at our action plan if you haven't already, just to see the breadth of work that we are undertaking. I'm in the process at the moment of writing our second annual report, which details the progress we've made against these outcomes and the specifics around each action. So that should be published in the summertime and will help describe what we've done and how we've done it. So I won't go into any more detail about that, but as I've said already, time-space compassion is a very key part of all of that work, and it's really threaded through and it has a strong connection to the trauma-informed work that Laura and her team are leading on as well. So, I think it's really important we're bringing these two topics together today. And I'll stop there, and I've managed to keep myself on time. So we're going to move on now and hear from a number of colleagues who are working across different services and organisations. These presentations are designed to provide some insight and learning into the different ways that colleagues have been joining the dots across suicide prevention and embedding a trauma-informed approach. There will be time for questions following all of the inputs, so please put your questions in the Q&A and the chat functions as we go, and we'll try and keep up with them at the end. So we're going to make sure that our speakers stick to time so that we've got questions for the discussion, time for questions in the discussion afterwards. So I'm going to come in and be really strict with time and wrap people up if they're about to run over. But I'm going to start by introducing Ross Reilly and Jane Grassie. Ross is from SAMH's SAMH's Café, and Dr. Jane Grassie is a consultant in emergency medicine in Fife NHS, who are going to talk about the work that they are doing in their setting. Ross and Jane, welcome.
Morning, everybody. As shared, my name's Ross. I'm a mental health peer worker in Fife. I use my own lived experience of a mental health journey and recovery to support people on their journeys. I work with the Scottish Action for Mental Health, SAMH, and I'm based within a project called SAMH's Fife, SAMH's Café. It's a project that's peer-led in Fife. We have drop-ins in the community where people can drop in for peer support, and we also work in partnership with my colleague Jane and her colleagues up at the NHS in Fife. So I'll hand over to Jane, who's going to give us a little bit of a lowdown.
Thanks, Ross, and good morning, everyone. I'm slightly overwhelmed by just how many people are on this webinar and how much expertise there is amongst you all. So I feel like a little bit of a fraud talking to you about trauma-informed care and suicide prevention, but I'm really delighted to be able to share some of the work that we're privileged to be doing with Ross and his colleagues from SAMH's and SAMH in the emergency department. So as Haylis already outlined, I'm an emergency medicine consultant and I work in the Victoria Hospital A&E in Fife. And as anyone who's been into an emergency department at any point in the last few years knows that it's a busy, overwhelming place, the environment of which is not well suited for anyone presenting in crisis. I am the mental health lead for the department, for our emergency department, and as such, interested in trying to improve the care of those who present either in suicidal crisis or distress, or also those who are coming in with issues of substance use, which often overlaps, as many of you know, with poor mental health. So I am utterly delighted to work alongside Ross and his colleagues Chelsea and the rest of the team. We are extremely fortunate in the department to have peer supporters. So peer practitioners will essentially support anyone that comes into the department with issues of psychological distress, suicidality, or indeed relatives of anyone who's distressed, or sometimes, in fact, staff members who might need some support as well. And we essentially see a wide variety of these presentations coming into us at all times of the day. And it's vital that we have someone who is on site, co-located with us, and that's exactly what these guys do. So I'm going to let Ross say a little bit more about how that works day to day, and we will just kind of back and forth in a wee bit of a conversational way, kind of try and talk you through how things work in the emergency department with our peer support service. Back to you, Ross.
Thank you. I'm not regretting not having slides at all. So yeah, mental health peer support, for people that don't know, is a person that uses their own lived experience to support other people, to be like a role model for recovery, to provide that sense of hope that things can improve, you can get through the most challenging of times. So I've been a peer support worker now for, in my professional life, 10 years. Before that, if you include my volunteering, it's about 15 years now. Like Jane saying, we have an awesome team in Fife at SAMH. We've got Chelsea, Jen, Fiona, we have Zoe, we have, I'm putting myself on the spot here, Lucy, and I hope I've not forgotten everybody. We've got 2 Jens now, so yeah. But they're inspired to support people, and it comes from the core of that, having lived through challenges, having lived through trauma, having lived through challenging thoughts. You can get a deeper understanding if you've been through it. You can understand the feelings that somebody's maybe going through, and I think that transfers into our peer support up at ED and the community. I think up at the hospital, it is a challenging environment at the best of times, let alone being in crisis with mental health issues or substance misuse challenges, you know, and to have somebody there that can sort of walk into the room and sort of, I don't know, just be there. I mean, we don't wear scrubs or anything like that. We don't wear name badges around our neck. We're there and we meet the person where they're at, and we provide that hope that, you know, things can improve. So we support people that are presenting with plans for suicide, people after an event where they've made an action to end their life. We support them the next day, and I think peer support is excellent at sparking that hope that things can improve and, you know, start to build a bit of scaffolding around the recovery. How do you feel about that, Jane?
Absolutely. I think we know from the evidence and from studies that have been done that those people who die from suicide are substantially more likely to have come into contact with emergency departments in the 30 days before completing suicide. And therefore it's a really important place to try and intervene, try and speak to people when they present in crisis to try and avert that. We also know that in general, mental health patients that do come to the emergency department kind of are more than twice as likely to be waiting around in the emergency department for more than 12 hours. And that's data from English emergency departments, but I think it probably applies to Scotland as well. So not only have you got people presenting in crisis who are at increased risk of completing suicide, but they're also hanging around for an awful lot longer in the department. So there's this fantastic opportunity for intervention, and it may be that those people who've presented have come in with other issues. It may be that they've actually presented with physical health issues, and it's only on questioning by clinicians or nursing staff that actually other things may come to light. And so there's fantastic opportunity there for us to come and find Ross or Chelsea or any of the rest of the team and say, look, there's someone here that it may just benefit from your support. And we know anecdotally from the work that you've been doing, Ross, that quite a lot of these people then will come and see you and follow up in the community after, which was absolutely fantastic, because we in the emergency department often feel a little bit helpless, that we're sort of sending people back and discharging into the abyss, and people may feel that way, especially if they've not got a requirement for sort of formal psychiatric follow-up, which not everyone, and I'd probably even argue that a majority of the patients that we see in crisis in the emergency department would not qualify for formal psychiatric follow-up, or may not benefit from it, but would benefit from just these brilliant conversations and support that come from the peer service, from people who have been there and understand it. As you said, Ross, it's all very well me coming along, however compassionate I might be. If I'm wearing scrubs and have the badge that says I'm the doctor or the nurse, there's a barrier there which doesn't exist with you guys. And there's a wee bit more informality there, which I think people really respond to.
Yeah, people choose whether to engage with the peer support. It's not forced on anybody. So it's like a shared conversation at the start where we explain our role and, you know, that sort of expectations and stuff. So it's totally up to the patient up at ED whether they engage with peer support. And obviously we go in with a bit of humility. We go in, you know, humbled by our own experience and stuff. We're not going in there with a set script that we have to kind of follow, or a set sort of treatment plan, not to get too medical because I'm not medical, but, you know, we go in and we start where the person is and what's important to that person in that moment. So it could be as much as getting through the next 2 minutes within the department. So that's what we'll focus on. You know, we don't go in, you know, like 6 weeks down the line. It's very much in the moment and moving forward from that moment. We try and be that source of hope for the person. Again, in the community, a lot of times the barriers to accessing services is set appointments and stuff. So we just operate a drop-in, so people can come when they deem it's right for them. They can stay 10 seconds, they can stay an hour, you know, there's no set time as such. And we work with the person where they're at that day, kind of thing. I think people feel safe with us. We seem to build up a fair bit of trust really quickly. And we take that forward with us. I think Jane's going to talk a bit about the hopes for the future.
So as part of our kind of trying to improve how we manage psychiatric emergencies and those presenting in distress to our emergency departments, not just in Fife, but I think across the board, this is a common barrier for being able to provide trauma-informed care is that actually the emergency department, the environment is not conducive. It's, as I've already alluded, and anyone that's been in one recently, that bright lights, it's noisy, it's crowded, and those people who are working in the department are time poor, and let's face it, some of us can be burnt out at any given time, which leads to compassion fatigue. So I think a big barrier for us to being able to deliver trauma-informed, sort of a compassionate approach to the patients that need it most is that environment and that sort of speed of and pace of the departments. And in our heads, we have a sort of pie in the sky idea of a nice separate emergency department that would be calmer, a more conducive environment, staffed with peer supporters and mental health professionals, addictions professionals, maybe also housing and crisis officers and things like that. So essentially, we've kind of been looking abroad and seeing if other places do things better, and there are other models. In Australia there's the Panda model, and in the US there's the Empath model, which is quite a compelling model of a sort of co-located emergency department that actually looks much more like a nice hotel lobby than an emergency department, where those people who present in crisis can be diverted or referred onwards to after their physical issues have been dealt with or de-escalated, and a more compassionate and timely, as well as with more time, approach can be made. So the NHS being what it is, it's difficult to just create a new space. You know, estates and hospitals are lacking in any kind of space like that, and so we're kind of starting a body of research to try and show that there is a need for this, and we've recruited Ross and Chelsea, who's one of his peer support colleagues, as co-applicants for a study which we've just undertaken to quantify exactly how many people are coming into emergency departments across 6 sites, including our own. And that study's just taken place a couple of weeks ago, and we're hoping to undertake more research just to demonstrate what the patient journey is, and to co-create that research with Ross and Chelsea and potentially other service users identified by them, to try and improve the services from the ground up. So that is something that we're kind of developing in Fife, and hopefully going to turn Ross and Chelsea not only as peer supported into peer researchers as well. So that's kind of the future for us, in the hope that we might be able to and work with other centres, Edinburgh and across the country, to try and implement a system that would allow better time, space and compassion for these patients.
Just very aware of time and stuff, but I just wanted to say, you know, we'll talk about these ideas, but on my journey, I was having a really challenging day. I'll just share this really quickly. I was a gentleman on a bench that kind of snapped me out of my suicidal thoughts kind of thing, and he was just chatting, just passing the time of day. So it's important that we're mindful of the whole spectrum that can help people. But yeah, I'm totally indebted to that gentleman, and he'll never know the difference that he's made, and why, you know, I don't know if I'd be sitting here if it wasn't for him passing the time of day. So I'm just giving him a big shout out. Thank you.
Thank you, Ross and Jane, really great. And there's lots of really positive comments in the chat, which I know you'll maybe now get a chance to have a look at, that you've finished your presentation. I'm going to swiftly hand over to Angi Pinkerton, who's the Trauma Informed Practice Officer in South East Ayrshire Council. Angi, are you there?
I am, thank you. Thank you for that, Haylis. I totally wish I had somebody with me today, so you don't all need to listen to my dulcet tones as for the next 15 minutes, so you absolutely have my sympathies. So good morning, everyone. As Haylis said, my name is Angi Pinkerton, and I am the Trauma Informed Practice Officer for South Ayrshire Council. And my job is to support all the things that Laura was talking about from the roadmap in South Ayrshire. Ultimately, some could argue that the Scottish Government commitment for a trauma-informed and responsive workforce stops at training. However, we know that supporting this transformational change requires more than training alone. So in South Ayrshire, we are focused on leadership, engagement, development and sustainability. Hence the acronym LEADS is the name of our project. This felt and still can feel very overwhelming at times. Developing a training calendar is relatively simple, says me after many sleepless nights and about 20% more grey hair. However, what we have to focus on is what is happening in leadership. How trauma responsive are our policies? Is everything we are doing quality assured? And are we meaningfully listening to and collaborating with people with lived experience? Then it can be really hard to know where to start. After all, as Laura said earlier, trauma is everyone's business. So it can be really hard to establish those priorities and make sure we're not taking that scattergun approach, as that will not really make any meaningful or sustainable changes. So when I first came across the paper published by the Improvement Service on cross-cutting agendas, it felt like I could finally see not only the bigger picture and how we can join the dots, but also how we can make sustainable changes too. Looking at the links between trauma and suicide, as we're all here to do today, is so clear. I mean, suicide often follows trauma, and then trauma follows suicide. So it feels kind of impossible to look at these agendas independently. Could you change the next slide, please, Jenny? So I'd really like Stephen's comment about knowing the difference between relational practice and transactional practice. And I really think that is something that we really need to become more familiar with. For those of you that are familiar with Bruce Peddy's book, The Boy Who Was Raised as a Wolf, you may be aware of his many quotes about the power and value of relationships, all equally important when working alongside other humans. However, the two that I feel really highlight my point in relation to this cross-cutting work is relationships matter, the currency for systemic change, and relationships are the agent of change. This idea that people, not programmes, change people, set my trauma brain into overload. Suddenly I could see all the commonalities across all these really large agendas that we have in Scotland, and could see the possibility of real change if we all came together. So when I first took post, I joined various strategic groups such as our Suicide Prevention Oversight Group, the ADP, the Promise, Adult Protection and Child Protection Committees, even worked on the kind of Bairns House rollout. And as time went on, I took on various roles within these groups, from owning actions in a delivery plan to co-chair. This helped me become familiar with large agendas within the local authority that I perhaps wasn't before in previous roles, but also helped me build relationships with key connectors across the organisation. I wanted people to know that I was an ally, and I wanted to progress their outcomes as much as my own, as they were all really important to the delivery of a trauma responsive South Ayrshire. I also began to work really quite closely with our suicide prevention leads across Public Health Scotland and the NHS, and this led on to me becoming more familiar with the model that's been spoken about this morning of time, space, compassion, where I then joined the facilitator network. I now co-deliver kind of workshops with colleagues to facilitate reflective conversations about how we, in times of change and austerity, provide time, space, compassion for all those we work alongside within communities and colleagues. I also took part in a recent podcast on how we enable these principles within our communities. All these things are so connected and important in the progression of a trauma responsive Scotland. So the relationships I was developing then allowed me to get involved in learning needs analysis that was conducted by Public Health Scotland to identify strengths and gaps in relation to the training of suicide prevention and mental health. The information from this also supported policy development in relation to how we support those living with suicide and self-harm. We are now also working on a pilot of trauma and aware communities with the Resilience Learning Partnership, where we are currently working with 2 communities in South Ayrshire with the hope of supporting community conversations that raise awareness of trauma. I passionately believe that an increased understanding of the impacts of trauma within communities will reduce suicidality across our communities. All these relationships led to various pieces of work that make my diary look very busy, but also help progress the work that I was doing myself. Not only did I have tangible changes, I also had a kind of support network from the people that I was making changes with. We are now at a stage in South Ayrshire where we have developed and successfully launched a new integrated impact assessment, which has the typical equalities impact assessment and Fairer Duty Scotland information, but also has a sustainability and a children's rights impact assessment. There is also a new section covering all these cross-cutting agendas. So this basically means that any piece of work coming from South Ayrshire Council is taking note of the impact of all the population supported by these large agendas. Next slide, please, Jenny. So we are really lucky to have secured in-house trainers that can deliver trauma, mental health first aid and taking action for whole health and wellbeing training. This means that we have the luxury of, while retaining authenticity, shaping the message for South Ayrshire. So the principles of time, space, compassion are woven through all the training I mentioned as the perfect illustration of how we are not only supporting becoming trauma responsive, but also how we support organisational and self-care. It is important to know that these principles that we all must have and demonstrate are actually intrinsic values rather than a kind of hat that we put on and off as required. We are also really fortunate to have many excellent examples of partnership working across South Ayrshire. However, the two that I think are really worthy of sharing with you is the Working for Wallaston project from Community Planning and at 40A and Compass Services from our South Ayrshire ADP Recovery Air Partnership. Both these projects have developed a multi-agency hub where support, people from kind of housing, DWP, community mental health, benefits, resettlement, communities, only to name a few, are based in the hub, and they're free to see whoever walks through the door. So, for example, traditionally, if someone came looking for a job but started talking about their thoughts of suicide or how they were struggling with addiction, how they didn't have enough money to pay for their bills and were about to be homeless, the officer would likely advise them to contact various agencies to help them with these other matters, while gently trying to pull their focus back to why they entered the building, to find a job. However, I think as we can all agree, with all, that going on in a person's world, coupled with our knowledge of how trauma impacts the brain and our windows of tolerance, it would be almost impossible to find and sustain a job. Now, this isn't the fault of the officer, but it's how our systems work. However, within these spaces, a person can walk through the door with complex needs and be met with a simple, okay, sit and have a cuppa. We can sort out a chat with, say, Susie from the homeless team, Fiona from suicide prevention, Barry from Recovery Air, or Laura from the Information Advice Hub. Now, I know that these persons' issues aren't all going to be solved with one appointment. However, it makes it more likely that they will re-engage and that sustainable changes become possible. And most importantly, that that person may not try to end their life that day, as the thing that people have talked about most today, hope, will remain. It also brings workers to communities rather than asking them to all come to us all the time. And this really helps to reduce those power differentials and kind of make support more accessible. We also try to ensure our policies take this cross-cutting agenda approach, and an example of this is our council plan, which not only has a trauma lens throughout, it has a dedicated section for these cross-cutting agendas to help raise awareness, but also to highlight that the council has a long-term commitment to these agendas that surpasses any changes to leadership and administration. We also recently developed a document that I spoke about earlier that aims to support staff when supporting others with suicide and self-harm. And this is called Pathways to Hope, an employee toolkit for suicide prevention and self-harm. This document was not only developed with a multidisciplinary team, including suicide prevention colleagues, it was also informed and co-designed by people with lived experience to ensure that it was a working tool that could be used for our staff. It consists of guidance for staff, training opportunities, local and national helplines, and a section on self-care. Next slide, please, Jenny. So my hopes for a future Scotland is that primarily we need a long-term commitment. It's similar to that of the promise, but without an end date when systems should be perfect, but an understanding that working within trauma responsive systems is an ongoing journey. Currently, our funding runs from year to year, and to be frank and probably a little bit cheeky, it doesn't even cover the lead officer's post without a contribution from the local authority. And this can make asking for additional funding kind of challenging. I'm in the process of trying to organise a local trauma conference in October that is being planned by multi-agency teams with little or no additional funding. And this is due to financial year cut-offs and budgets, and we totally understand that we don't have a magic money tree and times are hard. However, sustainable changes do not come for free. And also long-term commitment, makes planning all that much easier. We need to start taking a cross-cutting approach to our policies. We have excellent examples of partnership working locally, like those I mentioned earlier with hubs. However, issues always arise due to policy commitments and outcomes that inhibit that kind of work to progress. So the Improvement Service have already published a document that highlights these policy crossovers and commonalities really clearly. So I would like to see this work become part of all agendas. We cannot sustainably make changes when working on our own. And remember, relationships are the agent of change because people make changes, not programmes. I think that trauma is everyone's business for trauma and suicide message is absolutely true. We know that between 75 to 98% of people within our services have lived experience of trauma. However, I feel that the message gets miscommunicated along the way, and I would like to see more consistent messaging from leaders about the value of creating systems and services with the 5 principles and the 6 R's at the heart of everything we do. I would like to see that message begin in schools for our young people and be threaded through the curriculum. Living with the impacts of trauma can be very similar to living with neurodivergence, and systems and services are not set up to support either in wider society. We are still suggesting punitive measures are the only way to make changes in schools and communities and justice across all our mass media outlets. Thinking back to the projects I spoke of in the previous slide, I passionately believe working in this way, like this, not only makes our services more accessible, but also promotes recovery and reduces re-traumatisation. People don't care whose door they walk through, they just need help from us. So if our systems cannot change to recognise that people are complex with various issues of concerns and require flexible support, then all the excellent work on our individual agendas will be for nothing in the grand scheme. We'll continue to see reports across media that the promise is not living up to the commitment, that drug deaths are on the rise, that homeless figures are climbing, that our prisons are too full, if we don't start to take a holistic approach and focus more on our united outcomes than individual delivery plans. We need more money. We need more people, absolutely. But fundamentally, as Laura was saying right at the beginning, we need to start thinking differently and ensure that we do not remain within our kind of own policy silos in a policy and individual practice. So thank you very much for listening to me today.
Thank you so much, Angie. And again, lots of hearts and claps coming up on the screen there, and lots of positive comments and some questions for you in the chat too. Just a reminder to people that the Q&A facility is open. If you've got some questions, please pop them in there, and we'll come to them after we've heard from Tara French, who's the Scottish Government Digital Health and Care, and from Shannon McNee, who is from Carr, Gomm.
Good morning, everyone. Thank you so much for including us in the session this morning. We're absolutely thrilled to be here and to share some of the work that we've been doing across Scotland to support digital inclusion in many different areas and across the mental health landscape. My name's Tara and I work within the Digital Health and Care Division as part of Population Health in Scottish Government, and my colleague Shannon McNee from Carr, Gomm is going to tell you a little bit more about the work that Shannon has been taking forward to support people in digital inclusion on 2 different projects. But just to give a short overview before I hand over to Shannon, the work that we've been doing to support people to access digital services really stems from throughout the pandemic, we saw a huge increase in the range of digital supports and options across mental health. And what we recognise and what Audit Scotland published in August was that we actually still have a huge journey ahead of us in how we support people to feel confident in the way that they use digital as part of their wider health and care. And really the programme that we have been working on over the past couple of years has been funding 20 projects across Scotland, across mental health and many different areas of health and social care to really understand how we best support people to engage in digital services where they choose to, making sure that digital is absolutely a choice and that it's very much, complementary to other ways of engaging in health and social care services. And what we have been learning through the project is actually about the importance of trust, because digital is can be a very scary thing to engage in. There's a lot of fear around engaging in digital, particularly when it comes to health and social care, but also about that importance of a person-centred approach and really building relationships with people, and those trusted relationships that people have with people who support them, and looking at how that really supports people to get the best out of digital and to feel confident in engaging with digital. And what we've learned across a lot of projects is that digital ways of engaging is actually very much a lifeline for some people, and can be life-saving in many of the projects that we've been learning from throughout this journey. So I'm going to pop in the chat a little bit more information so that you might want to follow up with any links in your local areas of some of the work that's happening across Scotland, exploring that digital options and supporting people to engage. But I want to give the maximum time to Shannon to tell you more about the really important work of Carr Gomm. So I'll hand over to yourself, Shannon. Thank you.
Thank you, Tara. So yeah, thank you everyone for having us. And I think this is the largest group I've ever presented to online as well. So that's a wee bit daunting, but I'm very excited as well. So like Tara said, my name is Shannon McNee. I'm the Digital Inclusion Development Manager at Carr Gomm. And all our work is really focused on that kind of tagline in the blue font there of supporting people to get online in a safe and meaningful way. Have the next slide, please, Jenny. So if you've not heard of Carr Gomm before, we're a social care and community development charity, and we provide person-centred support to over 4,000 people across Scotland each year. And back in 2021, I came into post as the digital inclusion researcher at the time, leading up on our digital inclusion research project. And what that project was aiming to do was to really learn more about the digital needs of the people we support and our frontline staff to ensure everyone has the choice and opportunity to get online if they want to. And I should say as well, in terms of the services that Carr Gomm provides, it's really anyone that's needing that person-centred support. So it could be a home care service, it could be a mental health service, which I'll focus on today. It could be a supported living service for people with complex physical and cognitive disabilities as well. Have the next slide, please. And really, if there's one thing I would like for people to take away from the input today, it's really about seeing digital inclusion as a fundamental human right. And I was really kind of scribbling away, taking notes of the other presentations as well, because I think this links in really nicely with the context that's been set. So if we think about folk who have experience of trauma, who are experiencing suicidality, those folk are at increased risk of digital exclusion for many different reasons, whether it's the cost of devices and connectivity, whether it's the fact that they've just never had the opportunity to try and learn. It could be the accessibility of the devices themselves. People who are experiencing suicidality are at that increased risk of digital exclusion. And we're at this point now where having access to the internet, having access to a suitable device, it can't just be seen as this nice to have or this sort of luxury. It's an essential utility. So in support work, for example, if we were to go into someone's house that we support and they didn't have any running water, they didn't have any heating, didn't have any electricity, that would be a crisis that we would have to try and do our best to help with immediately. Digital now needs to be seen in the same way. When I was listening to the different kind of outcomes in terms of the Create and Hope Together strategy, what was kind of really popping out to me was really kind of seeing digital as sitting within outcomes 1 and outcome 3, because we're at this point where digital access is now often the means of people actually finding out about what type of support is available. But increasingly now, as Tara was mentioning as well, it's becoming the method of delivery. So if you're someone that's digitally excluded, that exclusion is then just further sort of impacting the inequalities that you're already experiencing in the day-to-day. So for us, and again with Angie's input as well, that theme of relationships, you'll see this coming through in the next slide here as well, please, Jenny, if we can move on to the next one. Because for ourselves at Carr Gomm, we thought to ourselves, right, we're already in the lives of hundreds of people each day who are at this significantly increased risk of digital exclusion. How can we think about using digital as a tool within that existing trusted support relationship? It's not as if digital inclusion support is a separate service and it sits off to the side as an add-on or an extra, but rather supporting our frontline staff to think about how can I be using digital to really support someone to meet their needs and achieve their goals in that person-centred way. Can I have the next slide, please, Jenny? And to simplify, I guess, the process that we support services to go through, it's these kind of three components in this sort of iterative cycle. So the first thing we do with the person we support is we help them to find that hook about getting online. What's that one thing or a combination of different things that helps them see the benefits in getting online? And the thing that's never worked for us, I'll say that up front, the thing that's never worked for us is focusing on health and care as the kind of opening door. It's always been about what's the person's hobbies, their interests, is there a specific goal they want to work on right now? And we take that hook or that combination of hooks and we set up a personalised plan with that person. So that's thinking about where are you currently in terms of your digital skills and confidence, and what sort of skills might you need to develop in order to reach that goal or reach that outcome that you're looking for. And we check in and refine that as needed, just as we would with work on any outcome and support. So it's that iterative process. If you have the next slide, please, Jenny. And I think the kind of key thing for me when it comes to thinking about how we can introduce digital into support is, again, it's just like any other core support we're providing, it's person-centred, so it's not going to look the same for everyone. Instead, it's thinking about, I guess, digital inclusion as a spectrum between digital enrichment and digital upskilling. So when I say digital enrichment, that's very much thinking about support practitioners themselves using digital as a tool, and with no sort of expectation that the person is going to be using that independently. So an example of that, for example, in our home care services, has been support practitioners using music to make a more calming environment, so using apps like Playlists for Life or Spotify. But right through to that digital upskilling sense of practitioners sharing their own digital skills and confidence with the people they support, so that person can then go on to use the internet independently for whatever goals or outcomes that they have. So that's sort of the approach we've been using in Carr Gomm, is this sort of broad spectrum. But I think if we go on to the next slide, please, Jenny, I can kind of give you a more sort of specific example of some project work here now as well. So Connected Lives was our Digital Pioneers Mental Health Funded project, which ran back in 2023 to 2024 in our Glasgow Integrated Mental Health Services. So our Glasgow Integrated Mental Health Services are very much sort of short-term support. So you're talking often a maximum of 12 weeks, and that's support delivered to people that are living with moderate to severe and enduring mental health conditions and are experiencing suicidality as well. And many with experience of inpatient psychiatric care. And what we were looking at in part of Connected Lives was, granted, we've got a very short amount of time together in that kind of maximum 12 weeks, but how can we be using digital as a tool to really enhance the impact of the support we're providing, but also then sustain that impact for someone moving forward as well when they move on from Carr Gomm at the end of that 12 weeks. Can I have the next slide, please, Jenny? So what that looked like was this sort of three kind of key steps here. So every single person that was involved in Connected Lives, that ended up being 75 people, I'll kind of sense check myself in the next slide with that, who receives access to an appropriate device and 12 months of unlimited data. So that concern about where am I going to get access to an appropriate device, where is my connectivity coming from, that was removed through the support of the grant funding that we had. So everyone had access to that straight away. Support practitioners were upskilled to provide that digital inclusion support as well, alongside the core support they were delivering. So again, what's that hook for someone, and what kind of skills might they need to develop in order to reach to that outcome or goal that they're looking for? And we also had the option of joining an online peer network as well, which ran weekly throughout the whole course of the project as well. So ultimately, what that looked like, if we're able to move on to the next slide, please, Jenny, is in terms of impact, we upskilled 9 of our frontline support practitioners as digital ambassadors. So they weren't solely responsible for delivering digital inclusion support, rather they were championing it in their service and cascaded that learning to over 40 frontline staff. across those 3 Glasgow integrated services. As I mentioned before, we reached 75 people. We intended to reach 60 at first, so we went over and above that, which was great. And our peer network sessions were really well attended over the course of that project as well. So that was things like bingo, pottery painting, quizzes, photography sessions. So it was creating that really supportive environment, which wasn't explicitly focused on mental wellbeing or mental health or trauma, but it gave folk that safe space where if they wanted to explore that, they knew that they could and they felt supported by that group. Can I move us on to the next slide, please, Jenny? So I'm not going to kind of hit us with percentages and numbers and things like that. I'm just going to pull out a few of these kind of circles here to tell you about before sharing a snippet of a story from a person we support. So from the kind of baseline period of starting in the project to then at the end of their 12 weeks, 64% of people felt fairly to very digitally confident. Often these were folk who had never used a tablet before. 64% felt connected to those important to them as well. So it comes back to this idea of digital having an impact across lots of different areas of folks' lives, but again, that importance of relationships, and 90% feeling able to access entertainment that had a positive impact on their well-being, which can be something that we take for granted, how good it can feel to watch your favourite programme on Netflix or read a book on a Kindle. So it's again, some of folks' first opportunity to access kind of forms of well-being like that as well. And that 81% of accessing health and information services, finding that helpful to manage their well-being, that was a really interesting stat for us, but it took a lot of time to get there. And what I'm kind of moving on to in the last few minutes of this presentation as well is, I guess, how that's still a bit of a nut to crack for us. So if we can ask us to move on to the next slide, please, Jenny. I think the idea of well-being and how digital can be impactful in this space is really, really well summarised here by Kirsty, who is a person supported through Connected Lives. So her name's been changed here, but I'll read this out for us in terms of Kirsty's experience. So she said, "I'm feeling not as doom and gloom. I feel there's light at the end of the tunnel. I don't need to sit and do nothing all day. I can get up and I can do things, even things like using the tablet to play calming music to help me to get to sleep. I'm getting better sleeps and feeling better in the morning for it. It might sound silly, but this tablet's completely changed me. It's done wonders for me and my confidence. It's helped me to meet people and make friends." And it's like literally, there's no better summary of how digital inclusion support can really have an impact in somebody's life. I think notably, the thing that Kirsty doesn't mention in that story that she shared with us is she doesn't explicitly speak about digital health and care and using kind of digital mental health services for self-management. This is still a conversation that's been really tough to kind of get right for us. If I can move us on to the next slide, Jenny, and I'll tell us a wee bit about the work that we're doing on that currently. So, like I keep saying, this idea about kind of digital health and care, even though our practitioners are like, I think you could really benefit for this. Like, I think, think about the time you'd say traveling to appointments and you can do it for the comfort of your own home. It's taking us a really long time for people to kind of see the benefit in that. And the reason for that is a lot of folk are quite comfortable using their device for what they're enjoying it for just now, your entertainment, your online shopping, using Facebook, using WhatsApp. And there's still that kind of distrust and kind of fear of misinformation, I would say, that Tara was alluding to earlier as well, that can still be that barrier to accessing digital health and care. So through the Digital Pioneers Progress Fund, we conducted a research project and we were asking that question, like, why is that? And really looking at exploring the attitudes of people we support and staff towards using digital health and care, predominantly for self-management of mental wellbeing. And what we were aiming for with that piece of work is to generate learning to inform the development of a good practice guide and how you can approach conversations related to digital health and care as well. Can I have the next slide, please, Jenny? So as part of this, we conducted focus groups with frontline staff, and those frontline staff were then upskilled to go and have really focused, good conversations about digital health and care with folk they support. And importantly, the folk we support were already using digital in some way. So they weren't people who were getting online for the first time. They were already using digital for something in their life, didn't matter what it was, but we knew they weren't currently using digital for their wellbeing. And so we spoke to those folk about what their kind of opinions were about digital health and care, and also gathered their honest feedback on free platforms as well that are currently available. So Near Me for virtual appointments with health professionals. They light an app that is currently completely free via NHS Scotland to everybody in Scotland as well, to support with feelings of anxiety and worry. And We Are Undefeatable is a partnership between UK health charities to provide access to accessible forms of movement to folk who might never have had the chance to move their body before. That's great. So I've got a wee minute left, so I'll wrap this up here. If I can bring us to the next slide, please, Jenny. And I guess the key takeaways from this piece of work for us was still this really strong message that digital health and care is not that strong initial hook. People who are already digitally connected and are already online did show an interest, but the really, I guess, thing that caught my eye was folk discussing their well-being still in relation to their hobbies and their connections with their community and the wider world, rather than thinking about it as their access to healthcare. So again, it's thinking about how can we approach these good conversations then, and how can we support our staff to have those. The big finding for us was that this sort of proliferation of digital health and care platforms isn't necessarily translating into awareness on the ground. So our practitioners didn't feel confident referring folk onto these platforms because they didn't know how they worked. They didn't know what the information, how folks' information was going to be stored. They didn't feel as if they could confidently support someone to use those. So we need access to that up-to-date information on these platforms, their potential benefits and reassurance on their security. And now more than ever as well, with the announcement of Scotland's digital front door, support practitioners and people they're supporting need to be meaningfully consulted in the design and the delivery of digital health and care services. And if we're saying that we're really wanting to have that time, space and compassion, and that we know we're moving towards this digital delivery of mental health healthcare, then the folk who are going to be accessing those services need to be involved at the point of design. And I think that's me just slightly over now, so I'll leave us with that, and any questions that you've got as well, my email's up on screen, I can put it in the chat. But yeah, just thank you very much for your time, folks.
It tells the story of a great session when there's so many questions and people wanting to come in, and we're really sorry we couldn't get to everybody today. We will do our best to respond to things in the chat, and please, as Laura said, please do take a look at all the links that have been posted in the chat. There's lots of really great information about things that have been spoken about today and about many other things from the quick whiz through that I've had. I hope that you found this session helpful. We've heard today about some of the ways that different organisations and colleagues are joining the dots across some of this work in really meaningful and creative ways. And we hope people are leaving here today feeling energised and inspired by the collective work that's happening across Scotland. I hope that this is the start of conversations about how each of us can collaborate and strengthen our links across these key agendas. I wanted to just point out the number of comments in the chat about looking after yourself when you're working in either a trauma-informed way or working in suicide prevention or self-harm. And I think that that's a really important thing for us to finish on today, that actually it's important to take some self-care, to take some time for yourself. So I hope that you're all taking a bit of a gap between this session and whatever else you've got to do for the rest of the day. You'll notice finally that there's a link in the chat for some feedback. It asks you a couple of brief questions, and we'd really appreciate you taking a minute to complete this to help us shape future events. The link to the recording and the slides will be shared on the National Trauma Transformation Programme website, so please have a look at that and do share with your colleagues and others that you know who would be interested. Thank you again for a great session, and I hope you all have a brilliant rest of your day and week.